All right, I think that is going. So first of all, thank you for being here. Happy Monday. Welcome to this month's Rural Provider Sustainability Community of Practice. This is our second community of practice, so we are still fairly new, but we're so excited to see some familiar faces and then also some new faces of folks that may have found us since September. So really excited to have you here. Just want to go over the agenda really quickly. We are just going to do some housekeeping, some quick introductions and chat, basically just some roll call to get an idea of what folks are joining us today and where folks are coming from. And then we do have the case management team here to answer some questions that have been coming in over the since our last meeting in September. So we're super excited to have them join us and go over some of the questions we submitted. We will have time for an open forum. That's just a chance for us to ask questions, share resources, spend some time connecting if we need to, and then we will go ahead and close you out here at the end and share some additional resources. So with that, I'm going to go ahead and just let us know a little bit about our purpose. So our purpose is really to connect rural healthcare providers through networking, resource sharing, and collaborative problem solving. We really want to foster shared learning and strengthen opportunities for partnership in our rural communities. We really open this up to a lot of different Medicaid providers to capture all of those who may be providing services directly, helping to connect rural members to providers in their areas, or impacted by the availability of services in their communities. So we're really opening this up for folks to be able to connect. And we're just so glad you're joining us today. I do want to remind you just before we get started, this is just a shared space for learning and connection. So we do ask that questions and comments are respectful and constructive, just so we can make the most of our time together today. And we're just so excited to have you here. So with that, let's do a little bit of some introductions. So I do have a lot of folks joining me from my team today, as well as the case management team, which you'll get to meet here in a bit. But my name is Brooke Snyder, and I'm a workforce and sustainability specialist here with the department within the Office of Community Living. I get to work on the workforce unit team, and my supervisor, Heather Johnson's here, and I also have John Hendricks, who's a colleague on my team that's kind of helping me monitor the chat and drop links. And so what I'd like to do for you all that are joining us is do just some quick introductions in chat. So I'd love to know your name and your agency, and really importantly, what counties you currently serve. And so we'll give folks a little bit of time to do that. You may be asking why we asked this question, or maybe wondering why we asked this. We just really like to understand who's joining us. And really identify what voices might be missing, especially since this is a new meeting. We want to make sure that we're getting folks from all across the state, and also different perspectives and different connections. So this networking piece, we like the idea of folks in different areas being able to network and connect, and then also the ability to compare quarter over quarter to measure our effectiveness in outreach and participation. So make sure that how we're reaching out to folks and letting folks know about this meeting is working, and then also that you keep coming back, that we don't run you off, and you keep coming back to share in this conversation with us. So hopefully it's useful. So thank you for dropping all that in the chat. We have some great representation here today. I'm really excited to see that. I'll give folks just a minute here. All right, I'm going to go ahead and move us to the next slide here. Let me get the phone number brought in. So we are going to have just some discussion points with the case management team. I'll level set a little bit on that, on what that looks like before I hand it over to them. So this was a topic request from this group in September. One of our stakeholders here in the meeting brought this up and said, hey, wouldn't it be great to have these folks here? We can ask them some questions. We can really dig into our points that we want to, and get a more specific interview or overview versus kind of the general overview that we've gotten in other larger meetings. And so this was a request from this group. Since our meeting in September, we've been collecting questions for them. We shared them ahead of time, so they had lots of time to prepare and make sure they were coming with the information. We also took the themes that we heard in all of our listening sessions. So earlier this year, a lot of you were involved in that too, in those listening sessions. And we took a couple of those points out of that too that we heard over and over again, in addition to what we heard in our other meetings. And we turned those into questions too, so we could just really get the most bang for our buck out of this meeting. So we'd like you to use chat and the raise hand feature for discussion through this. And so I do also want to just put a plug in here, because I'm eternal optimist, that as we discuss this information and its challenges, I think it's equally valuable to acknowledge what's going well. So we encourage you to share improvement processes that have run smoothly, any issues that have been resolved. I think understanding strengths help us better support solutions too. So if you wouldn't mind throwing some kudos out there, we would love that as well. As we talk through this, but just really excited to have this team here, and really grateful for their time and the presentation that they're going to be giving us. So with that, I believe I'll stop sharing and hand it over to Ryan and Amanda.
Yeah, and I'll just start. I want to say thank you so much for inviting us. It is a pleasure to come to this group. For those of you that don't know me very well, I come from very rural areas. I've spent a lot of my adult life and childhood in rural areas and have a really big passion. And, you know, we couldn't do the work we do without providers and advocacy partners and our case managers. And so just appreciate and respect all of the work that you guys do each and every day to support the members you serve in your community. And I know that as the case management director, I oversee the case management quality and performance. So our team is responsible for all of the activities and service requirements for the case management, the quality oversight, the day-to-day operations. Boy, has there been a lot of change, and there has certainly been some challenges. And for all of you as community partners and providers working alongside both your case management agencies and the department navigating this, I know has been challenging, and I just appreciate all of the work that you've been doing. Ryan and her team oversee the quality side of our case management. And so Ryan is going to be the lead today, talking through all of the great work that's happening over there, as well as the work we have to come. Right? Case management redesign is still pretty new, you know, depending on how you look at it. Some days it feels like we've been in it a long time, and other days, you know, it is just a short blip in long-term care policy timelines. And so we're really excited about where we're at and where we're headed, and grounding from where we came. So Ryan? I think I forgot to say my name. I'm Amanda Lofgren.
Your name was fully on the screen, so you're halfway covered. You're good. Ryan Lubitz, as Amanda was sharing, I am the section manager here in the Office of Community Living in the Case Management Quality Performance Division, overseeing all things quality management for our case management agencies. Just a little background on me. I've been with the department a little over 10 years. Prior to being in this position, I worked on our consumer-directed programs in our benefits division. And prior to that, I was a case manager in the field working on our waiver programs for 13 years. So I've been boots on the ground, fresh out of college, moving to Colorado, doing case management, back when we used to have it based out of our local mental health centers, have ended up here just, you know, hop, skip, and a jump away, even though I'm only 29. So it's amazing how time flies by. So appreciate seeing your faces today. I did put together a slight PowerPoint because it keeps me structured for how I can flow through, because you submitted some great questions. And so I tried to lump them together into some buckets so we could walk through some roles and responsibility documents and how my team, my section, does continuous quality improvement. So I'm going to take over the screen here, so bear with me for just a hot second. Make sure I get the right screen up. All right. So we always call ourselves CMQPD, because don't you need just one more acronym in your life? Sadly, after close to 11 years here, I dream about acronyms. I greatly appreciate you, Jose. All right, so I always like to start with what our purpose is. You know, Amanda did a great lead-in for us, but we've actually been doing some kind of strategic work internally a little bit to talk about what our purpose is. And, you know, it's not just Amanda and I that are in this division. We work with a ton, and when I say a ton, not nearly enough, I would say, what, 20-ish people are in our division across 3 sections that create policy, they create operations, and then we do the quality oversight. But we are more than just, you know, just the quality that we're talking about today. So it's important to just touch on that. But we developed a purpose statement recently that we exist to provide strategic leadership and oversight so that the CMA ecosystem achieves consistent delivery of quality case management and access to long-term service and supports for Colorado residents. So only 2 acronyms in that purpose statement. So I feel like that's a slight win versus I think we started with maybe 12. I'm joking. It was probably more like 5. All right. So one of the main themes that was submitted was on roles and responsibilities. And I actually see some faces here today that worked on some of our roles and responsibilities documents that I have for you today. And I'll put these in the chat after I'm done presenting, so that way you have them as well. The links are also on the screen, and I'm sure, Brooke, do you email out the slide deck afterwards?
I do, yep, and
Okay.
we post it as well, so yeah.
So for some reason today, if you don't grab them when they're in the chat, we'll make sure that you get them because they'll be linked in the PowerPoint. But we had a work group, Amanda Lofgren, keep me honest, 2 years ago, I'm going to go with, though, let's be honest, it's Medicaid years, so that could really be anywhere between 1 and 3 years. We worked with a group of case management agencies and advocacy partners to develop roles and responsibility documents for case management agencies and case managers, because we felt it was a common question that was coming up as to what is a case management agency role and responsibility versus what is a case manager's role and responsibility. And I have a slide that I'm going to share in a little bit that has a whole bunch of bubbles around the different, I guess, touch points that a member may have, whether, when they're working through the continuum of Medicaid. But, case managers are, in my very biased opinion, one of the strongest backbones of our ecosystem to provide support to our members, to get them in the door, usher them throughout services, get them needed support. And they need their case management agency to provide them with great leadership and great oversight. So I digress, but we worked as part of a work group, and I think we went through 3 iterations of roles and responsibilities to come up with the master sheet. But ultimately, case management agencies, so they assist families and individuals with accessing necessary home and community-based services, including now Community First Choice, and other supports to meet member needs, including doing intake assessments, intake screens, intake assessment, then eligibility determination, service plan development. They arrange for services. I know some people on the call today are from provider agencies, so coordinating with those provider agencies, coordinating externally with our regional accountable entities, our advocacy partners, our community center boards. They monitor those delivery of the services. So checking on what is the utilization of that service. Is the member utilizing it? Do we need to make changes? Is there a problem with the service? Does the service meet their needs or not meet their needs? And so doing a lot of that service planning and then doing that coordination. They do monitoring contacts. So we're required through our federal agreements to do quarterly monitoring contacts between the case management agency and the individual receiving services and their representative. And then they also do termination and discharge from services. And this is not the exhaustive list. The exhaustive list, I think Amanda might have helped me out and put in the chat. Correct me if I'm wrong, give me a head nod. Okay. The link to the 2 documents, so you could take a look at them at your leisure, because they are quite lengthy, and to try to summarize that into 1 page was going to be quite difficult. But, they complete our critical incident reporting. They make our referrals. They are there to ensure people know about all those great services that are available throughout Colorado. Okay. And then we go into
one little tiny thing, right?
Yes, go ahead.
We actually did it. We implemented this last year in January.
Thank you.
And had all of the case managers that were employed by the CMAs at that time do an attestation that they had reviewed and looked at the roles and responsibilities for the case managers. And then each of the CMAs did it collectively as well. So I think that's a helpful piece of information.
That's a great call out. I appreciate it. We announced it via operational memo with that requirement to ensure that everyone was able to take a look at it, really go through it, staff, upper staff with the case managers. And then, yes, we have a learning management system that they were required to go into and attest that they had reviewed it. So we can track it here at the Department for Learning and Development. And then all new hires go through that same process of reviewing it and attesting to it in our learning management system. All right. So on this slide, one of the questions was, what is the role of the Community Center Board versus the RAE versus case management agencies versus provider agencies? There was a variety of nuances and threads there. And I do see some of our CCB partners on the call today, so you can always feel free to raise your hand and jump in if there's anything that you want to add for color, because I never want to give the impression that I can adequately represent the great work that you do, but I can sure try. But we have our Community Center Board partners, and they're agencies that are designated by the department. And their responsibility is to leverage available local or regional funding to address unmet needs for individuals with intellectual and developmental disabilities, or IDD. And counties that don't have a designated CCB or don't have that local funding, they consult with their county case management agency for potential resources. So we've got our Community Center Board partners throughout Colorado. And then we have our regional accountable entities, or our RAEs, and they're responsible for promoting member health and well-being by administering the capitated behavioral health benefit, establishing and supporting networks of providers, and coordinating medical and community-based services for members in their region. And so you'll get the link with our ACC Provider and Stakeholder Resource Center webpage. And then we have also provider agencies, which some of you are on the line. And provider agencies are responsible for developing a service plan specific to the services they will provide, rendering the services according to the service plan. They do hiring, training, monitoring, overseeing staff that provide services. They follow all the required regulations if they're licensed. They go through CDPHE, so they have that licensure requirement. They coordinate with the member's case manager, other service providers, do incident reporting, etc. And like I said, this is not an exhaustive list of everything that all three of these entities do. It's just the tip of the iceberg. So this is a nice slide that I admittedly borrowed from somebody else from a presentation that they did that shows some of the intersection of our case management agency and RAE roles. And so you can see, while a RAE may be working with the primary care provider, some of that work, they'll be coordinating, services for physical and behavioral health needs. And then you've got the case manager over there. They're doing service plan development. They're doing ongoing monitoring and doing the assessments, making referrals, but they overlap in that they coordinate across providers and community agencies to really get our members the services that they need. And so I like to think of them as being lock and step with each other, because if somebody is having, perhaps mental health or behavioral health needs, that case management agency is going to look to that RAE to help lean in that space. And if somebody perhaps is having issues with their assisted living space that might be triggering something there, that RAE is going to be looking at that case management agency around, let's talk about the services that the person is getting. How are we supporting this person holistically? So this is a very simplistic slide. It doesn't get into all the complexities and great work that they do, but they do have some overlap for that care coordination. And then this is the doozy of a slide. As you can see, I couldn't fit every bubble in here possible for all the touch points that support a member. But, for community partners, we have the RAE and we have the CCB, but we also have, and we have the CMA, but we also have Department of Human Services. So overseeing all of the members' Medicaid applications and financial eligibility, We've got provider agencies, as I talked about before. We have transition coordination agencies who are helping individuals discharged from hospitals and long-term care facilities. My goodness, we have PACE organizations, adult protective services. There is just a large amount of support throughout Colorado that work together with that Medicaid member at the center to try to ensure that we're meeting people where they're at and getting their needs met. So hopefully you're like, this is a great slide. I'm going to put this up on my vision board and look at it later. All right, so I'm going to pause there before we talk about Community Advisory Committee and just really check in with you all as it was the question around, who does what, whose roles are what, whose responsibilities are what, to see if there was any questions related to that you wanted Amanda and I to maybe touch base on today or dig a little deeper into.
Hi, I see Elaine. Go ahead.
Is there anybody else that has their hand raised before me?
No, you're
okay. Okay. All right. Okay. Well, I want to, I need to go back to, the TCM versus case management. Okay. I'm really struggling with, and Amanda, you are fully aware of this. We've had conversations before. The level of monitoring or connection or person-centered planning or whatever is definitely falling to the wayside. And that's what leads into some other questions about accountability and who's monitoring things. Because I think what we're seeing, and I know this to be true, what we're seeing in a multitude of areas is that these case management agencies are so big and their caseloads are big, they're huge, but they're not able to do the level of case management that TCM requires. And I think either do TCM or just do straight case management, one or the other, because and I don't know, Tom Turner and I've had discussions over the years about, targeted populations and the things that they require, the support that they require from a case manager. And I know, Amanda, you have said before that probably we were doing a lot more than maybe we should have been doing. I don't know. We were just trained to do that over the years back in the day to provide pretty extensive case management to people with intellectual and developmental disabilities. I think that although this system has been developed and there's some good pieces and good parts that have come out of it for sure, I think that's the huge area that is suffering for people with intellectual and developmental disabilities. I just don't think we're getting to what their needs are. I've attended a lot of service plans. I've attended a lot of, I've sat in on assessments, whatever. And it's just not happening. And it's not any one person's fault. I don't want to blame case managers or anybody else, but we're not getting to what we need to get to with people with IDD. So I struggle with it. I think data is being met. I think you've got a system that, man, I mean, these case managers, they're putting the data in. You guys are getting good, probably reports. You're probably getting everything that you need to support what you're doing in Colorado with the federal government. I think that's wonderful because we do have to have that to support, money coming into the state. I get it. But the individualized support is just not what's happening. So I don't know. I think that's a big discussion that probably we should have down the road. So that's all I wanted to say about all of that. So thank you.
Thanks for that, Elaine. And I will go into on the slides further as we go along into the quality oversight that we have of case management agencies. So hopefully, we can kind of go through that and then revisit if you wanted to dive into any specifics.
Yeah, and I'll just add, I don't want to give the impression that we are at a place where everything is perfect and this is what it's going to look like. I think that we transformed and took 50 years of a community center board system and 30 years of a single entry point system, and we had private case management structure for CHCBS waiver, and created a singular case management structure with the goal and intent to become more and more person-centered over time, but we needed the foundation. And so I think that we're not there. I don't think there's a case management agency out there, nor the department, that would say we've arrived. We know that there's a lot more work to do, but we also know the reality of where we just came from with, the public health emergency unwind, implementing a brand new IT system that had 188 defects that we've been working through, as well as challenges with transitions. And there are things from the CCB world that were added into the CMA contracts. There were things from the SEP world that were added in. There were new things. And there were changes with the intentionality, sorry, intentionality of creating that foundation and framework, acknowledging and recognizing there's going to be some adjustments and pivots by everybody, not just on the case management agency side, but also on the provider side, as we uncoupled case management from direct services as well. And so I think we have a lot of work to do as an ecosystem across everybody to move towards more person-centeredness, but also being thoughtful and intentional about creating requirements based on a disability versus an individualized need. So I just want to frame that, because I apologize if I gave an impression that we are solid. We are not. We're getting data as a way of monitoring and measuring stability, so that we have good checks and balances in place, but we know that there's a lot of work to do. So I appreciate the questions and the comments.
Thanks, Amanda. Thanks, Ryan. Thanks, Elaine. I also see Tiffany as well, and then we'll hit the chat real fast. Tiffany, I think you're muted, so we can't hear you.
I just wanted to piggyback on that a little bit, and it's the community partners sharing data. We are seeing such a huge problem with community partners sharing data with each other, or crossing data. And I work for Pikes Peak Respite Services. I'm the Chief Operations Officer. So obviously I deal with this a lot with our clients, but even me personally right now, DHS and HCPF communicating with each other on my son's case, it is a disaster. We've been working on this since July, and I just got another letter saying that his services are ending because HCPF doesn't have all of the information that I've turned into DHS. DHS is saying, oh, well, we don't have this from HCPF. TRE is saying, oh, well, this is what's happening and we don't know. But I think the communication across community partners is something that we tend to just kind of gloss over a little bit. Yes, HCPF is doing their due diligence. Yes, DHS is doing theirs, and the case management agencies are doing theirs, but no one is communicating with each other. And I just see that as another really big roadblock in getting people the services that they need. That's all I wanted to say. Thank you.
Thank you, Tiffany. I'm going to call out, looks like more of a comment than a question from Sarah in the chat, but I'm just going to read it out so it's captured on the recording. Sarah says that she agrees with Elaine. She has concerns about case managers not advocating for the wants and needs of the people they case manage. She still has big concerns about monitoring of service delivery matching, which is in the service plan or being billed. So just a comment from Sarah, kind of piggybacking off of Elaine as well.
All right. I'm going to move
us. Can I throw out real
ahead.
quick? I'm sorry. Excuse me. I just want to say that I think with that communication, with your bubble, your slide here, it is hard to coordinate all those people. It is hard to coordinate all those agencies. And this is why I think, unfortunately, I don't know, well, no, that caseloads need to be smaller. Because to do a really good job to pull all these people together on behalf of your child or all the people on your caseload, that's a lot of work. And nobody is saying these case managers aren't working hard. So I think that should be something that is reconsidered over time, that you look at the caseload sizes. I have heard from case managers who have done single entry point stuff who are having to be trained to do IDD, and they're just shaking their heads and saying there's so much. And I mean, when you talk about people with syndromes, however many syndromes there are out there for people with IDD, it just boggles the mind. And to do a good job with a person with IDD and to coordinate all these people, it takes a lot of time. And I think that's something that you guys need to look at in the future, are the caseload sizes to be effective for people not that are IDD also. So, thanks.
Thanks. Appreciate that, Elaine. When we set the 1:65 ratio, it really is the beginning point, and brought down caseload sizes that traditionally had been 150 at one point. And so I don't ever think that door is ever closed. It's really a matter of always keeping our finger on the pulse of case manager roles and responsibilities, coupled with our funding sources, to be able to figure out what can a case manager manage within the work that we're giving them, coupled with what can we as a state afford to pay for said services, and trying to find that sweet spot. And I think the 1:65 was our start, and we'll always keep looking at it. It's not definitely not set in stone. All right, I'm going to move us forward, and I apologize for the lots of words on the screen. This was a question that was submitted related to our community advisory committee that we have each case management agency hold. And someone submitted a question around how do the advisory committees help HCPUF and CMAs maintain accountability and continuous improvement? What are the key roles and responsibilities of the community advisory committees in that process? So I am by far not your community advisory committee expert. I outreached to Nicolette Cordova, who works within the case management division, to help formulate this slide. And so this was information that she asked me to share with you all around that community advisory committees. They provide regular participant-centered oversight. So they bring participants' lived experience, perspective, and subject matter expertise about issues and needs unique to their community. They review the CMA's complaint log on a monthly basis. They offer input and recommendations for local resolutions and corrective actions. They document recommendations in their meeting minutes template to send to the department. We require formal CMA responses, monitoring, follow through. They advise on policy and procedures and service deliveries, outreach. They create a transparent, accountable feedback loop that drives that continuous quality improvement and ensures compliance with our regulations. And there's a relevant memo that we will put into the chat and make sure that you all get. But I really look at them as a way to guide the CMA to always ensure that there is a point where people are being representative and can talk through, here's what's going well, here's what we need to change. Let's look at our complaint log. Let's talk through some things, and let's report that to the department, because you need to have your own internal processes so we can help keep our finger on the pulse. Amanda, is there anything you want to add? Because I know Community Advisory Committee was something that you were instrumental in bringing about in Colorado.
Yeah, I would just add that, we do not want to have the space ever where unique needs in the community are not being addressed or represented through the case management agencies. Like, there's always going to be policy that needs to be consistent statewide. Like, we have to have that. That was a goal and objective of case management redesign. But there's also unique needs in different areas across the state that need to be addressed. And there needs to be flexibility and a good understanding of what those are, and then reported back up to the department. And so the Community Advisory Committee was really our approach to allowing and preserving those protective needs of the various areas of the state. And so, Jose, I see you raise your hand because I think you were pretty involved with us from the beginning of this as well. So I'll yield the floor to you.
Thank you, Amanda. And I appreciate you summarizing what we have done and what the CAT is about. And I also would like to add something else that I think is important to keep in mind, especially now, because what you're saying makes a lot of sense, right? Every need is unique. And what some of the risks that we're running right now, and I'm talking about some of the emergency rules that are being brought to the MLD, for example, is that we run the risk of not complying or not following the same policies that we have always followed when applying for exceptions. For example, exceptions, right? Appeal runs and things like that are at risk, in my view, right now, because of what the department is requesting. And I understand the urgency, right? I completely get where we are standing, and we definitely at the ARC, at CCGT, we do not stand against them. It's just that we want to make sure that we all are on the same page and that we are not making decisions that may harm unavoidably people. Because, for example, the exceptions policy, right, that Hickox is suggesting, and I know that the emergency rule was full and that there is a normal rule being introduced at the MSD, but for example, that gives us a lot of possibilities for trouble down the road. Because if we reduce the timelines to respond for an appeal, for example, we're putting the whole state at risk. The other thing is that because of the gaps that are being suggested, which we understand are necessary, but we need to make them all, for example, eligible for appeal and exception processes, exactly because of what you're saying, right? What you're saying is exactly on point, that every case is different. So while we understand that we are in a big crisis and we need to take care of that crisis, we also need to keep in mind that Colorado is Colorado. And we, Colorado is a champion of trying to reduce harm, even when we need to accept some of it.
I appreciate that, Jose, and Ryan and I will certainly circle with our team that's just working on that. I think, kind of weaving that together is I wouldn't want 15 different exceptions processes for a benefit program or et cetera. But what I would really want is a little better understanding in maybe Western Slope. Maybe there's certain things that are going on that are driving a subset of members that are needing an exception to that process that is unique to that area. What is the reasoning there that then the case management agency through the Community Advisory Council can have a good understanding so that can come forward to us around policy? I think I saw somebody from the Eastern Slope, right? Like there might be something unique there. Sarah, the mountains, right? Like you are always facing some unique things there. And so I think that's where it's like, policy framework should be the same and consistent, but then understanding the uniqueness of the members and where do we have flexibility in that process or those policies through like an exceptions process, et cetera.
Exactly. Thank you.
Yeah, thank you.
That's extremely important to us. I am actually preparing a brief for Arca Finance, but I suspect CCDC wants to see that too.
Yeah.
So
Yeah, and then I think, making sure we have consistent training and messaging and policy guidance that everybody's hearing collectively, but also that case managers can look to.
Yes, so that if we say, well, yes, it's true that we're calling these services as this percentage, right? Or this number of hours. However, if there is a client and more, and it's well documented, let's do this instead.
Awesome. Thank you.
Thanks, Jose. Thanks, Amanda. I did just want to call out a question from Elaine in the chat. So does HCPF review the notes from the community advisory committees? They communicate through the CMA to the CAC, spending quite a bit of time on policies and just a quick review of complaints. We have monthly review of complaints, but not discussing the trends or ideas for correction.
I would say, make sure you have that conversation with the CMA and the Community Advisory Council, because some of it is to be driven by the council itself, but they do submit, forgive me, I'm on the top of my head, I don't know if it's monthly or quarterly, but they do submit to the department the trends. We don't get all of the details, but we do have reports submitted to the department.
Thanks, Amanda.
So if
sorry.
we've raised issues in the CAC, are you seeing those issues that have been raised by the council?
I would have to circle with the team, Elaine.
Okay.
But right now I will take that back and circle.
Yeah. Or is it just a deliverable? You're looking at the trend, whatever. Because yeah. Okay. I'm curious about that. Thanks.
Yeah.
I will say if there's a concerning trend, that is something that is brought from Nicolette to my quality team in terms of like, hey, is there an opportunity for us to do monitoring or oversight? So I'm going to move us to provider referrals. So one of the questions submitted was who ensures that CMAs maintain an updated list of available providers for requests for proposals, and how is accuracy in this process monitored to support member choice and compliance with conflict-free case management? And so we actually have all case managers directed to use the following tool. It's the Health First Colorado provider. It's the .com/find/doc/find. Words are hard today, sorry. Find doctors / and it's under HCBS provider type to search for HCBS and IDD providers. So we refer them to use that to ensure that they have the most up-to-date information available for provider, like who's a provider and a provider. Depending on where you're at, there could be providers coming onboarding, they could be offboarding. It's just fluid that way. In terms of oversight of that, actually my section, they review as part of our performance and quality reviews and our quality improvement strategy reviews, which I'm going to touch on in a few slides from now. They review member choice documentation that's in the care and case management system record for each member. So they are taking a look at that to make certain that member choice is documented. Brooke.
I'm just thinking back to the conversations we've had and how this theme kind of came up. And I'm just wondering, so if I am a provider agency and I happen to look at the Health First Colorado tool and see that my information is incorrect, how do I go about updating that or making sure my information in that is correct? And if that's not your team, I understand. I just want to understand how we can make sure that's corrected.
Yep, that one I don't know. I would have to get back. I'd have to check with like a Joanne Svenningson over in that section to see if they had any knowledge resources they could help us with there.
Perfect. So just for the group, I'll ask that and see if we can get an update on that. So if you are a provider who's seeing issues with your information in that tool, we'll figure out how to get that updated, how you can update that yourself. So thank you. Thank you.
The only additional nugget I can just add is it comes directly from when providers enroll through Gainwell. And so it comes from that feed. Now, I know in the past we have identified glitches. So I think checking back and then getting that to the group is great. But I just wanted to share that. It comes from the provider enrollment process.
Okay. Thanks, Amanda.
Mm-hmm. Appreciate that. And good call out, Brooke, because yeah, if somebody does have an update that's needed, that is a good area to focus on. Next was translation services. So there were a couple of questions around roles and responsibilities from translation. So the question that was submitted is, who is responsible for ensuring language translation of forms and materials for families? And how is Spanish and other language accessibility being addressed in current case management processes? and who is responsible. And so I pulled this information actually directly from case management contract. So each case management agency also is required to post their contract on their website. So this is all publicly available to you. But case management agencies are responsible for providing language assistance services, including bilingual staff and our interpreter services at no cost to any individual or member. It should be provided at all points of contact in a timely manner and during all hours of operation. So they may have translation like staff readily available that are employed by the CMA to provide that service, or they may contract for that service using a language line or another translation organization. And then within it, they also are required to have at each CMA a member and family liaison. And that position is responsible for the internal CMA policies and procedures to ensure member and family access to communication in their primary language and any reasonable accommodations that are needed. Amanda, anything you wanted to add there before I jump over to Jose?
Nope, go ahead, Jose.
Okay. Jose, love the background, by the way.
Thank you. Thank you. I have a question because what you're saying goes straight to something that's being worked on at the legislative level and also at the policy level. Regarding language access. Going to a higher level, going HCBS, I know at the capital, but at HCBS, what does that look like translating documents? Because I know you guys don't usually need translation for live things, right? Except in some cases, maybe a client calls or something like that. But translating of documents, who is in charge of that at the HCBS level?
I would guess our communications team would be at least who we would start with, Jose. We only ask this team just specific to case management agencies, and so they're not able to speak to that unless they just have some nugget of information. But I would anticipate that our communications team would have resources. And see, Amanda, I see you came off mute. Do you have anything to add?
Yeah, I was just going to share that it's a combination with our communications team and our member experience center. There's a team that is charged specifically with doing all of the translation services and the contract that translates our materials. Not all of our materials are translated for the case managers. They have to translate some of them on their own. And so that's the partnership we have there. But that team does all of the department's translated materials and contracts it out. Excuse me.
Thank you.
Mm-hmm.
Okay, I'm going to move us forward. So this is the bulk of the information that was asked was really around case management oversight. And so I wanted to spend this last portion of time together really going through the work that my section does to oversee case management work for, what we look at as a continuous quality improvement cycle. We do, you see case managers have training, we develop policies and procedures, we audit on it, and then we go back through that cycle again of, okay, what do we need to retrain on? What policies and procedures maybe need to be clarified, changed, what have you, but we are always in a continuous quality improvement cycle. And really at the core of that is doing the case management oversight to ensure that we understand boots on the ground how things are going. So there is 4 components that my section dives into. And at the end, I'll have a slide that is outside of my section, additional oversight that is performed of case management agencies. But my section works on quality improvement strategies, performance and quality reviews, and I'm going to have a slide on each one of these, so I'm not going to go into detail here. Targeted case management reviews and stabilization metrics and meetings. So within that, I'm going to start us with quality improvement strategies. Internally, we call it QIS because As I said before, why would we give up an opportunity for an acronym at any point? But QIS, so the most simplistic way I can describe it, it's our waiver agreements with CMS. We have our Medicaid waiver programs that we are approved to operate. The federal government is paying 50, depending on the program, 50-ish. You know, if you look at CFC, a little bit more of the bill for services. And in return, we have assurances that we've provided them on oversight of our roles and responsibilities. And so we report to them annually on the performance of our waiver programs and our agreements. So within that, we do it once a year. We work on this from July to September for the prior year. They're based on the performance measures that are currently in our waiver programs. It's a statistically valid 95.5 sample of the overall waiver. So it doesn't break out to a 95.5 sample per case management agency. It's the entire waiver population that we pull data from. We create a review tool, and we get the results to report it back to CMS based on the overarching performance of the waiver. Then we also share those results with each case management agency, but because it's not statistically valid sample size per case management agency, the sample that could pull into it for each agency, it may not be reflective of that agency's individual performance if they only had perhaps, and this happens sometimes because it's a randomized sample, 2 or 3 members that pulled into the sample. So, but we use that, we share those records right back with the case management agency once we're completing our audit to say, okay, here's where we're finding opportunities for improvement or correction. Here's where we want you to do remediation, to report back to us how you're going to address any performance issues. You know, if it's a missing record, documentation, and then require training. So if we're seeing a theme where an agency, you know, based on their sample, or even statewide, if we see a statewide issue and it might not even be specific to a certain agency, we'll require retraining on a topic regarding that, so that way everyone gets a refresher to ensure that everyone's understanding the requirements for our performance measures and that they're doing the job that we have outlined and they're responsible for. So for QIS, and this is a very bullety slide, apologies, they're looking at the level of care. So they're looking at, is the level of care assessment that somebody has, was it completed accurately? Does the documentation and the scoring, does that align? Were the date and the timeline? So what day did you assess the person? Did you complete your activities within the timelines? Is the narrative there? If it's an intake assessment, do you have that professional medical information page? If it's one of our kiddos, traditionally that had been on the children with life-limiting illness waiver, that waiver, which as you may, if you have experience with it, requires a life-limiting attestation form. So we looked for that. We go through service plan and we look at, there's an inventory of needs within one of our bridge systems, and we match that up to the assessment to say, if you have an assessed need, is that aligning with either a paid or unpaid support or a community resource? We're looking at personal goals, not service goals, but what is the individual's personal goal? The contingency plan. So what is your backup plan? If services don't show up, or you need to move, or your assisted living or host home needs to change, or that you can't continue in that service area, what's your support system? We look for service plans and then the revision of service plans. Are you getting your needs assessed? And then if things change, is that documented? And are you getting that statement of agreement that you're signing off on to approve that change? We also look at the waiver services that are authorized and documentation of provider choice. We look at scope and type of services, amount of services, frequency and duration of services. So we look at all the services and go, are you getting the, according to your care plan, or are Are you getting the services that you need from, are we seeing them being billed? Are you getting them according to the frequency duration that you were supposed to be getting them from? And then we have critical incident reporting, checking on timeliness and documentation there. Same with restrictive interventions and rights modifications. And then we look at documentation overall in our waiver for medical professional visits. It's a data pull that we do to make sure that people are coordinated with medical care that they need. So this obviously is subject to change based on federal agreements. Sometimes we add more in, sometimes we combine things, sometimes we parse it out over the years, but this core has predominantly remained. All right, so that's the one time a year review that the team does for the performance of the waiver. Then they move over and they work on performance and quality reviews. And so this is a statistically valid sample size for each case management agency. So we work internally with the data team, we pull a sample. This takes several months for the team to complete because of the volume of records. So we're going through end-to-end processes, looking at more than just quality improvement strategies, but we're going through every step of the intake process, looking through every monitoring contact, not just for a specific activity as broken out before, but really doing a holistic record review. And so within that, they're looking also at agency policies and procedures, staffing patterns. It's a lot. It's busy. The workbook's really complicated with multiple tabs. But they look at this last year, they looked at 1,725 member records. To be able to give a report back to the CMA, a data workbook with all of the information, to then initiate, if needed, a corrective action plan, identify trainings, figure out if we need to do technical assistance, as well as any policy clarification that's needed. So, kind of what Amanda was talking about earlier, I never want to give off the impression that everything is solid and it's like we've got, no problems, no issues. There's always going to be that loop where we're going to see something. If the case management agency is struggling with something, we have to take a critical look at it and go, okay, is it just that CMA or is that statewide? What's driving that? What is it? The training? Is it the quality oversight at the CMA? Is it department guidance? How can we look at it holistically, identify what's happening, and really target that approach accordingly to get the improvement of where we need it to be? And we did launch a new IT system, as Amanda was saying. And so that, I think definitely this last, the first year of having that created a hardship on our case management agencies with the appropriateness of documentation because they were learning a new system and trying to figure out where they put things. I am seeing that improve, but that is a really good example of best, you roll something out. We did the training, we were giving hands-on assistance, but sometimes, people are going to struggle when they're using something new. And then we've got to go back and figure out how do we retrain them? How do we target in to make sure that we're getting everything that we need from that case management agency to ensure that we have a holistic record and picture of the person's needs and supports. Okay, so again, just a very bulleted list of some of the things, and this is not exhaustive, but again, it's referrals and intake, the level of care assessment, service planning, monitoring context, notice of actions. So that's that. If you're like me and you've been in the system quite some time, we like to also call it the LTC 803, or notice of action. The developmental disability and delay determination, service plan revisions, rights modifications, activity logs are formerly known as, some people call them case notes. And then further criteria as we identify it. So we're like, yep, we're going to dive in and add this in as we launch new programs and services. All right.
Ryan, before you move on, can I just add a couple?
Yes, go for it.
Okay, you did a great job.
Give me a chance to breathe. That'd be great.
This is the relationship we have. So a couple things that I think is helpful for me is I think of QIS, quality improvement strategies, as more of the compliance with the federal requirements. And so different than the performance and quality reviews that we create the tool. So on the QIS, we have little flexibility in terms of how that's administrated and what is inclusive of the items we're looking at, because it is a one-to-one federal requirement and what we are reporting to them on an annual basis. The performance and quality review, for those of you that maybe were more intimately involved with case management over the years, we historically did it every 5 years when we had, 47 case management agencies. This is the first time we've redone the whole entire tool. It is going to be conducted on an annual basis for all case management agencies. And they too, just like on the QIS, are provided all of the information and the workbooks. It has a lot of PHI in it, so they can actually remediate the file and address the service plan or monitoring or whatever they have found directly with the member and get that resolved. But it also allows the department to keep a better check and have checks and balances and then follow up on a regular cycle. So this is new. We've only done one so far. We did not do corrective action plans this year because we also needed to make sure that our tool that we were using is reliable and is going to achieve the outcomes. So we're making a little bit of tweaks from the first round we did to the second round based on feedback and kind of understanding how it works. But we will have these on an annual basis going forward for all 15, which is a huge change in how things have been historically done. So just wanted to give a shout out to Ryan and her team for putting that process in place. And then as part of the contract, all case management agencies are required to have what's called a continuous quality improvement plan. And now that we've done the first round of performance and quality reviews, many of them are updating that to align with their own internal checks and balances so that they're using similar based tools.
Elaine.
Hey, yes, well, I went through a lot of those over the years. So meeting the assurances, so the data that you're collecting, which is what happens, helps meet all of that. What I wonder about, and I think Brooke, there was some further discussion about monitoring, because we're seeing that in the past, case managers would monitor a little bit more on site with individuals. They'd talk to a person and really get a good feeling about how things were going. And because it's changed, that the face-to-face monitoring in case management is not as much as it used to be. My question, I think, when we had met before was, who is monitoring the providers? Because what would happen is case managers would be meeting with, and remember, I'm talking in the world of IDD, we would meet with an individual, the person would identify, oh, something wasn't going good at home, or something like that, and we could bring it up and talk about it and get attention to get things dealt with. With that not happening as much, who's monitoring process? So I'm just throwing that out because that's kind of where I was going with the monitoring piece, not so much monitoring case management, because I know that there's a lot of checks and balances in that. I know with the QIS and all the other stuff. So I just wanted to throw that out, but I think it's kind of hard to get to what's going on on a quarterly basis if you're only doing a face-to-face on not a quarterly, but what, people only have to be seen once a year now?
Well,
or am I off a little bit?
Oh, no, that's okay. I was just going to say, so it's a requirement for 4 quarterly monitorings.
Mm-hmm.
A minimum of 1 has to be in person, but all 4 of them can be in person, depending on the individual's preference.
Right.
And then you have also their annual assessment. So there should be 5
Mm-hmm.
touch points that can be in person, depending on member preference. Amanda, did you want to add something?
That's where I was going to go. Exactly. The only other thing I would add is we got a lot of feedback after we had some flexibilities with virtual versus in person from members and families of really wanting to maintain that as an option for members. we worked really closely with CMS. They don't love that we even have the one in there. They want them all to be, but we pressed really hard and said, based on feedback experience, this is truly person-centered, because not everybody wants somebody in their home. But we do know that there's, monitoring, the purpose and intent is also for health and safety checks as well. And so trying to balance that. So that's where we landed to a year minimum.
Right, and I get that people don't want, they feel that's an intrusion. I'm not really talking so much about hard fast going into the home. I'm talking about case managers are so on their computer doing all this data stuff that maybe they don't go to the day program as much as they used to touch base with people, or maybe they don't see, go to somebody's, I don't know, have coffee with people or do whatever it is they do to connect with people, because they're so driven to get information in. That's what I'm seeing, Amanda. And it's those just random connections that you would make with people that all of a sudden you'll hear something, that I'm not happy with, with my provider in SLS, because, they never talk to me about what I want to do. Oh, well, how does that happen? Well, I never get to, whatever. I mean, it's just random things like that is what I'm getting at. I don't know that case management is able to get out and about like they used to. Gotcha. Is where I'm going with that. Okay. Not hard, fast getting in the home and disrupting people's lives. So
yeah, sounds good.
Anyway, okay.
Thanks for that.
Thanks.
Okay, I'm going to move us forward to targeted case management reviews. So we also do targeted reviews of our case management agencies outside of doing that quality improvement strategy and performance and quality reviews. And these are really more one-off reviews that are done, and really the theme of it or what we're targeting can change. Hence the name. So I put in this slide, when is a targeted review performed? And so whenever we identify themes from prior reviews, we like to go back and do some spot checking, whether improvement is occurring following the training. So if we see a deficiency, we'll go back in a few months after training and be like, let's spot check 30 cases for an agency and see if things are improving or declining, or are they the same? So we can identify, okay, did what we do work? Do we need to do something else? We take a look whenever there's an increase or a decrease in enrollment and utilization to dive in to say, hey, was there a policy change? Maybe a procedural change? Is that going well? What are we seeing from it? Are we seeing higher enrollment? Are we seeing lower enrollment, higher utilization? Is there any trends we can identify there? We look at the complaint trends that are received by HCBS staff. We have our complaints and grievances form to look for common themes to say, okay, I'm seeing 30 referrals came in the last 2 months regarding the same agency, same topic. Now let's dive in and pull a sample and see what we can see to see if we can support what's going on, to identify that theme and do it like a corrective action process. And then as I was slightly talking about this before, and I was talking about the utilization enrollment, we do post-implementation reviews of our new programs and services. So for example, like Community First Choice has rolled out as of last July. And so we're taking a look and doing some spot reviews because we've got case managers who are newer to authorizing and utilizing the direct care service calculator, make sure that they're understanding how to utilize it and authorize services appropriately, and try to do any course correction before we would hit maybe that 1 year mark. So that way, if somebody is doing things incorrectly, we can get them on the right path to ensure that they're authorizing services according to rules and regulations. So again, not an exhaustive list, but I always joke, it's also, if Amanda identifies something, also an Amanda we should put that as a bullet item subject to Amanda. So basically really diving in and honing in on these, identified targeted issues. The team is working, actually, this is where we're at in our cycle right now. And then finally, within my section, we also meet with our case management agencies and have them submit data to us. So they submit monthly data on what we call it the stabilization metric Google sheet that they have to submit to the department, outlining where they're at with their pending referrals, intake screens, initial level of care assessments, anything that's past due, so past our 2, 5, or 10-day timelines, their past due continued stay review level of care assessments, delayed service plans, any missed monitoring contacts they have, and their staff vacancy. So that way we can track and trend what's going on with that agency. This really came out of case management redesign. This is a newer process that, following case management redesign and the changes that the system was going through with launching the care and case management system, member records moving to different agencies, employees moving to different agencies, merging of people managing waiver programs, coupled with the public health emergency, unwind in our stabilization actions that we were trying to take to stabilize our case management ecosystem. We thought, let's get monthly data, keep our finger on the pulse of what's going on with agencies. And so we started this after case management redesign, and it has continued. So every month, each agency, all 15, have to submit data to us. And then we're meeting with case management agencies to review their data with them. And the cadence on that varies depending on how the CMA is doing. So if a CMA's data is showing any signs for concern, I'm going to meet with them twice a month to go through it and talk through what help support changes are needed, either on our side, the case management side, both monthly or then bi-monthly every other month, depending on their performance. The majority, I would say, are at least 10 are bi-monthly, and then the other 5 fall in mostly to the monthly category. So wanted to share that information. Amanda, is there anything you wanted to add there?
Nothing I can think of.
And it's a great opportunity for us to be also, one of the things I have on this slide is staff vacancy. It's a chance for us, while we may be looking at their data and their metrics on how they're doing for quality, understanding staff turnover is really important to be able to understand what's happening at a case management agency, because that directly impacts the members and the services that they're receiving.
Turnover, but also the ratio, the member to case manager ratios, and because it can ebb and flow, but also as we're kind of going back to your comment earlier, Lane, we are seeing agencies now like really understanding like how do they do assignments, how are they managing their caseloads, and starting to think about how can they maybe do it differently to better meet the needs of members or individuals and their case managers. And so we're seeing them put together some business plan proposals, I think, and we should probably be seeing that after the new year, I think, a little bit more, to really try and figure out, can they do some caseloads based on individuals, needs, or maybe they're going to do a hybrid caseload, or maybe they'll have, if people are in like a caseload of just residential services, and maybe that could be a little bit higher and then offset some of those lower caseloads needs. So we're starting to see some of the agencies really start to think through that and what that would look like. And our message has been, like what Ryan said, 65-1 was where we started. We didn't know what that would look like or what that would feel like on a day-to-day level. And we always had some flexibility in there based on CMA needs. But I think now we're really going to start to see some, I think, better business models to support the work going forward.
All right. And this is my last slide. Additional oversight that's outside of case management are quality section division. So within other divisions, within the Office of Community Living, we also have teams looking at complaint and grievance report reviews, national core indicator satisfaction survey results, financial audit reviews, reviewing escalations. Our state general fund programs have their own auditing processes and procedures. And then we have a contract compliance team as well. So while we are one part of the wheel, I would say we're the biggest part of the oversight wheel. There is a lot of support that we receive from other areas to to dive in. So I'm going to stop presenting and turn it back over to Brooke.
Yes, thank you. We have a few minutes for maybe some additional questions for this team before we let them go. Again, we did try to collect all the questions beforehand just for preparation, but if you have anything that you'd like to follow up on, I'd like to give you just a few minutes to do so. So feel free to use chat or raise your hand. Tom, please.
Hi,
Are we
everybody.
charging for questions?
What do you want now, Tom? Okay.
Good to see you.
You too. Thanks for doing this. This has been real helpful. I had submitted a question late, and it kind of goes back to some of the information on slide 18, talking about things that are late. If there is an assessment that is late or a service plan that is late, etc. In 8.7202, it talks about how if a service provider ends up providing services and that isn't billable because the paperwork wasn't in place, what type of process is available for providers to try and get paid for those services? I mean, it speaks to that being a case management agency, financial responsibility, but I have no idea if and when that would happen, what kind of process would we need to go through?
Yeah, great question. Ryan, you want to start and then I can.
Yeah. So Tom, that's a great question. You know, what I would say to start with is completing the complaints and grievance form on the department's website to be able to elevate that to the department so that way we can take a look at that individual record to identify what has occurred. That's really the first step for us to be able to understand whether or not there was something that the case management agency failed to meet from their contractual responsibilities. And then we would have to take it on a case-by-case basis there as to what the next steps would be once we did an investigation. Amanda, anything you want to add?
No, that was beautiful. Thank you. You know, the only thing I would just add is I think sometimes too, there's a lot of, and the reason why we have it structured that way is because there's a lot of moving parts, right? There's a lot of variables that can go into that as to the why. And sometimes it takes an individual to spend a lot of time kind of sifting through the different records, having conversations with the provider or the case management agency to figure out what's going on there. We are issuing authorizations to use this language and holding case management agencies accountable if they truly are liable for it. But, you know, I think especially on the front end, there's a lot of documentation that has to be gathered, forms that have to be signed. You know, I think one thing with a group of providers here, I'll just say is please make sure one of the things we've been hearing about, Tom, this is not to you, but this is to everybody. Case management agencies are having a hard time getting service plans signed back from providers and also members, right? And so those are the types of things that we're going to dig into all and really look at it. But yeah, use the escalation form. And then that will come to the department and they'll triage it to the right subject matter experts to do that work. And I think in general, you know, if you have an issue and this is a little bit more broadly, I was going to say this before we opened it up for additional questions, is my ask is always to start with the case management agency, right? Trying to figure out what's going on there. Was it maybe there's a personnel issue, maybe there's a misunderstanding, or maybe there's just some personality clashes going on. Who knows what the derivative is, but have that conversation with the leadership team at the case management agency. They're working really hard to try and build those relationships and rapport and address any issues that they're having. And then if you don't get there, then reach out to the department through the escalation form and we'll navigate from there. And Ryan and her team will dig in, or, we also have our operations team that digs in.
Okay, great.
That was more than you wanted, Tom.
No, it wasn't. That was really helpful. And again, that's not been an issue, but it's just been something that I've questioned given the fact that it's in rule. Okay, yep. How does that rule get implemented? So.
Yeah. And, as a reminder, and I don't think this is news to any of you, but, we are turning the PARs, that one section of the PARs have been turned on. And then after the new year, all PARs will be turned back on for HCBS services. And so we have been having a lot of conversations about the need for timeliness and making sure that those are in place so providers can get paid.
Okay. Thank you.
Mm-hmm.
Thanks, Tom. Anyone else before we let Ryan and Amanda go. All right, I'll let you. Yeah,
I'll
Amanda.
just start where I just want to finish where I started. Thank you, thank you. You know, we have to have providers in every area of the state, and you know, the evidence by you guys showing up here and asking us to join is it tells me how committed and dedicated you are to serve the rural areas, and we can't do this work without you. Our case management agencies can't do their work without great providers, and I really appreciate you all. And I know that you have had challenges as a result of the work that we've been doing to address the changes and make improvements in the collective system. And it's not always easy. And I think together, right, like on the case management side, there's opportunities for us. On the provider side, there's opportunities. And having conversation and dialogue will always bring us closer to finding a solution to the problems and understanding the root cause of those so we can work through them together. So I appreciate it. I know I always don't have the answer you're hoping, but I think that we are making a lot of progress. It's going to take time.
Thanks, Amanda. And I think I'll leave an open invitation for both of you. You are welcome anytime to come back to our group. We'd love to have you. In fact, I may invite you back at any point. So thank you so much. And
thanks a lot
Ryan,
for attending.
Yes, thank you.
Anytime. Thanks, everyone. Have a great day.
Thank you. All right, let me pull up our slides really fast and take us out towards the end. I just wanted to get into open forum really quickly, because I did have a request from a provider here on the Western Slope. She wasn't able to join us in real time, so she wasn't able to bring this question to the group, but I do have someone who is interested in connecting with another rural provider to discuss background practice or background checks and hiring practices and kind of what that looks like for you, knowing that, you know, the agencies have a little bit of leeway with that, but she wants to just talk through what that looks like for your specific agency in a rural area. And so if anybody would like to sit down and chat with her, just exchange a few emails, I know she would really, really appreciate that. And so I'm going to put my email in the chat if you're interested in connecting with her, and then I can introduce you. Because I think that is part of what we would like to do with some of this information and this community of practice, as well as be able to connect rural providers with one another to be able to ask questions and share sentiments. So if you'd be willing to do that, I would so appreciate it. I would take the lead in getting you connected with her. But yeah, so that was one of our open forum questions. Can I open the floor to anyone else with any other announcements, questions, thoughts? Please for help.
I have a question, Brooke. Oh, I'm sorry.
Sure.
I'm sorry, Kim, or whoever that was. How Kim indicated, and all of the case management agencies are indicating that kickoff made the call to make them the gatekeepers for funds, right? For our distributions and services, benefit levels, etc. Perhaps you don't have an answer right now, but perhaps you can send it to me. Does that look different in the rural area than in Denver, for example? And are they taking into consideration the different necessities that exist given the lack of providers or the big amount of providers, for example, in Denver, or the lack of workers for direct care, things like that? I would like to know how those points connect in different areas of Colorado, what HICOS is looking at from that perspective. That
Okay.
is my question.
Yeah, Jose, I don't have a full, because I think it's going to be a lot of resources and information for you. So what we'll do is it's going to be us and it's going to be my team, and we're able to talk to kind of like the workforce considerations, what's be done in that. There may be some information in the rural transformation plan that Colorado just applied for. So let me get some information to you. I'll email you, I have it. And then we can circle back on points in that maybe you want to discuss a little more. Tom, perfect.
Hi, Brooke. One other thing, and I know this isn't really on the agenda, but you would be really disappointed if I didn't mention this.
Yes.
Because we have talked so much about the dwindling enrollments of people into the waivers in rural areas, I certainly understand the reduction of the churn by 50%, but I just have to make the comment that that's just going to make that worse. You know, we have rural providers that haven't seen a new enrollment in years, and that's just going to exacerbate that. So again, I know that's not really anything you can do about, and I understand why it's necessary, but it's going to make that worse.
Yeah. Yeah. Thank you, Tom. I appreciate the comment and just being able to capture that. You had a lot of head nods. I think that's probably a shared sentiment. So thanks for naming that. Any other hands? Kim, I see you on mute, please.
Hi, this is Kim Searles with Beneficent, and I just wanted to mention that for these people that are in the rural areas, if they're worried about qualifying for long-term care Medicaid and they think that they may not qualify because they make too much or they have too much, then we would be a good option for them. We do serve the entire state of Colorado, so that includes the rural areas. So that is why I was jumping on here today, is to specifically say that, I mean, I know there's the pie, and I know it's a smaller slice of the pie that think that they make too much or have too much. But those people still need to be served as well in the rural areas all over the state of Colorado, for that matter. But I just want to mention that. The website for Beneficent is doinggoodforothers.com. I did put that in the chat. And I also do an educational training class for business professionals for different organizations. So I do 2 open classes every month. Like, for example, I'm doing one tomorrow. So any of you, if you'd like to learn more on how I can assist you with some of these different cases, then you are welcome to take one of those educational training classes.
Kim, one question, Kim.
Yes.
Sorry, Ruth. One question, Kim. Do you do this specifically focused on different areas of Colorado, or do you do it statewide?
We are statewide. So that's why I'm saying even the rural areas, it is important for them to get served as well. Right. Mm-hmm. And even if they're in a situation where they have maybe a friend or a loved one that they want to get paid to be a caregiver, think about that as well. Right. Because sometimes in the rural areas, there may not be staff in order to assist those people. Well, if they can have like a neighbor or a friend or somebody get paid to be a caregiver, then we find that also that helps those families as well. Right. So, but the big thing is that these clients don't need to necessarily, quote, spend down everything that they have worked so hard for in order to qualify for long-term care Medicaid. If they come to us, that is, we can help them through that process to be able to preserve for the next generation.
And are your presentations for free?
Yes, I do educational training classes for free. And I will actually put the website, you just go to the educational classes and just register for one of those classes.
Thank you so much, Kim.
Yeah, that's good information. Thank you.
Yeah,
Yes.
thanks, Kim. Thanks, Jose.
Mm-hmm.
And we'll make sure that that's captured too, Kim, for folks who'd like that additional information as well. Okay. Thanks for being here.
Yes, thanks for having me.
All right, last few minutes. Anything else for open forum before I zoom us out through closing? Heather, please.
So really just more related to putting people's folks about the care worker tax credit. There is a new one for long-term care, but in general, Brooke will hopefully send that out. I know she'll send it out to folks. And we're having Get Ahead Colorado come in January to the Compensation and Benefits Action Group to do a presentation on tax credits in general, right? A lot of us can't be in the business of giving tax advice, but we want to be able to connect folks to where they can get tax advice. And so just putting that on your radars, if folks can't come, it will be recorded. And you're also welcome to just check out Get Ahead Colorado's website or share that as a resource to your workers, members, anybody who's filing taxes or may want to file taxes, getting some information out to them. I also know that Get Ahead Colorado will do some presentations in Spanish or some stuff in Spanish if you need them. So just put that on the radar. It's December. Lots of folks start to file in January. So just wanted to make note of that as well. Thank you.
Thanks, Heather. Yeah, we'll make sure we get the Get Ahead Colorado website out to you all. I did drop a link in the chat for the Direct Care Workforce Collaborative. That's where it lists out that meeting in January, the compensation and benefits, to join us for that as well. So this is just a reminder of our next meeting will be Monday, March 9th. I would like to request, just maybe if you want to shoot me an email, if this day and time works. I've had a couple folks come to me and say, hey, actually our community advisory committee for Rocky Mountain Health Plans is during this time. And so we're not able to join in real time. And so if a Monday at 1 o'clock doesn't work for you, if you just want to shoot me an email at the Rural Sustainability email, I'll put it in the chat here, and let me know a day and time that works better. I'll just kind of go on consensus on if we need to reschedule this in the new year. And so then of course be on the lookout for a change in date. We'll update the OCL calendar if we need to, but and then we are on the lookout for new topics. And so again, this one came to us, the case management Q&A came to us from September from a request. And so if you have a topic you'd like to request, we have a topic request form. You can also just email me as well. If we do a Q&A type event, I will make sure that we have questions to those folks the 15th of the month before, so they have about 3 weeks for preparation. So Tom, I apologize, I didn't communicate that the last time, and so that's kind of how we do the Q&A or the topic request is the 15th of the month before the presentation. So that would be February 15th for the upcoming March meeting. And then our next collaborative is Wednesday, January 14th, and that website is in the chat as well. And in addition to all of those things, we've started a couple here just to keep an idea of what's happening on the state and federal level on impacts to Medicaid. I've started both of those. The top one is more related to federal actions, and then the Medicaid sustainability in Colorado's long-term services and supports is more Office of Community Living related. And so just a place to keep updated on that. And I would just like to say thank you. Thanks for being here. We saw a jump in participation and a jump in attendance. And so I'm really excited to see kind of where counties are and see that our reach has grown a little bit. And I'm really grateful for you to being here, and we'll see you next time. Have a wonderful holiday season, and please take care.
You too. Thanks, Brooke.
But one last thing, I am not sure I understood who's guiding the OCL calendar now, but it's completely out of date for 2026.
Yes, yeah, we're
do that.
Yeah, no, thank you. Thanks. Yeah, John Barry retired, and so we're kind of switching over. There's like a new team that's kind of taking that on. So we'll make sure we get that updated for 2026. I know they're doing requests for calendar invites for 2026. So we'll make sure we have that done hopefully here in a little bit, but it is on my radar. Thank you, Jose.
No, thank you. Yeah, I saw that.
Yeah, we're getting we're too close to 2026 for it to be waiting. So thanks, Jose.
Thank you, Brooke. Bye-bye.
Bye. All right, thanks, Tom. We'll see ya.